Hi, good morning, doctors. Today is the 38th day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing together for MRCGP International AKT exam. Today we are at chapter 18, 635 page, Hematology and Immunology. Let's start reading. Page number 636, Hematology and Immunology. Full blood count and ESR. The most commonly requested blood test is the full blood count. Reference ranges are a guide only. Normal values are affected by the ethnicity, age, and pregnancy. For mild abnormalities as well as in well individuals, take laboratory advice to avoid other investigation, over investigation, or over referral. Red cells, anemia, erythrocytosis. Anemia page 638, erythrocytosis page 6655. Mean corpuscular volume MCV, decreased mean corpuscular volume, microcytic anemia in 80 less than 80 picoliters. Iron deficiency anemia confirmed with decreased serum ferritin. So whenever you find an iron deficiency anemia, microcytic anemia, you confirm with reduced serum ferritin. Rarer causes like thalassemia suspect if MCV is too low for a level of anemia. Congenital sideroblastic anemia is very rare. Raised MCV, macrocytic, that is more than 100 picoliters, vitamin B12 or folate deficiency, alcoholic liver disease, drugs, azathioprine and chemotherapy, hemolysis, pregnancy, hypothyroidism, marrow infiltration or myelodysplasias. So myelodysplasias, the bone marrow is not able to produce proper sized RBCs. That's why there will be macrocytic. Again, B12 folate deficiency, alcohol, liver diseases, drugs like azathioprine and chemotherapy. White cells. Normal white cell count is 4 to 11 into 10 power 9. Reasons for individual components to be higher or low are summarized in table 18.1. Platelets. Thrombocytopenia. Decreased platelets, that is less than 150 into 10 power 9 per liter. Causes are decreased production, marrow failure, alcohol, megaloblastic anemia. Decreased survival of the platelets, pregnancy, ITP, viruses, disseminated intravascular coagulation, SLE, lymphoma, thrombotic thrombocytopenic purpura, hypersplenism, genetic diseases. So either there is decreased production because of marrow failure, alcohol or megaloblastic anemia, decreased survival, that is pregnancy, ITP, TTP, DIC, SLE, lymphoma, hypersplenism, genetic disease, platelet aggregation like with heparin, 5% of the patients causes heparin-induced thrombocytopenia or HIT. Drugs, example omeprazole, furosemide, quinine and trimethoprim. So this quinine which is used in nocturnal leg cramps can cause thrombocytopenia. Again trimethoprim, T for trimethoprim and T for thrombocytopenia. Also it will cause bone marrow suppression. Omeprazole and furosemide. Omeprazole, which we routinely used for as a PPI, will cause some thrombocytopenia, and furosemide. Thrombocytosis, that is increased platelets more than 450 into 10 power 9. Causes are primary thrombocytosis, reactive thrombocytosis. Primary thrombocytosis is fine. Reactive thrombocytosis due to infection. Any infection will cause raised platelet count. Some infections. Malignant diseases, acute or chronic inflammatory diseases. Pregnancy, after splenectomy. Iron deficiency or falling hemorrhage. So when there's an iron deficiency, there will be anemia along with thrombocytosis for or following a hemorrhage. 50% with persistent unexplained thrombocytosis have a malignancy. Yes, there are many cases where they have said whenever there's a thrombocytosis along with dysphagia or other symptoms, you need to send for a 2-week wait referral for cancer pathway. So persistent unexplained thrombocytosis have a malignancy. Consider urgent chest X-ray if more than 40 years, urgent pelvic ultrasound if in females, age more than 55 years, breast vaginal discharge and hematuria, routine referral for upper GI endoscopy if age more than 55 years. So upper GI endoscopy referral criteria, age more than 55 years, and nausea, vomiting, weight loss, reflex dyspepsia, and other upper abdominal pain. So then you are suspecting a gastric malignancy. So in this case, there will be thrombocytosis also. So when there is persistent thrombocytosis, first you will consider urgent chest X-ray in more than 40 years old, urgent pelvic ultrasound if it's a female, if age is more than 55, and it's a or have a vaginal discharge or a hematuria in men, female and male. Routine referral for upper GI endoscopy you have to consider if age is more than 55 plus the nausea or vomiting, weight loss, reflex, dyspepsia or upper abdominal pain. Any GI malignancy symptoms plus thrombocytosis. You have to refer for a upper GI endoscopy. Pancytopenia, decrease in red cell counts, white cell counts and platelets. Causes are aplastic megaloblastic anemia. So aplastic anemia is fine, parvovirus B19, or megaloblastic anemia can also cause pancytopenia. Bone marrow infiltration or replacement by lymphoma, leukemia, myeloma, secondary carcinoma or myelofibrosis. So bone marrow infiltration can cause pancytopenia because there is no space. It is infiltrated by fibrosis or by lymphoma leukemia cells. That is why there is no space for producing normal blood cells. Hypersplenism, disseminated tuberculosis, SLE. SLE is a cause of pancytopenia. Paroxysmal nocturnal hemoglobinuria. This is one of the cause of pancytopenia. Erythrocyte sedimentation rate, ESR, rate of fall of red cells in a column of blood, a measure of acute phase response. The pathological process may be ineffective, may be infective, immunological, malignant, ischemic or traumatic. So the process, infectious diseases, immunological diseases, malignant diseases, ischemic causes or traumatic causes can cause raised ESR. Normal values increase with age, females more than males, in raises in patients with severe anemia. So ESR is high in patients with severe anemia. Differential diagnosis for white cell count changes. This table, there is the differential diagnosis for white cell count changes. White cell type, normal range, percentage. Neutrophils 2 to 7.5 into 10 power 9, 40 to 75% of neutrophils are normal. Causes of increased neutrophils, bacterial infection, physical injury like trauma, burns, surgery, inflammation, polymyalgia rheumatica or rheumatoid arthritis, myocardial infarction, pregnancy, malignancy, leukemia, disseminated malignancy, drugs like steroids. Okay, so we already know that bacterial infection will cause neutrophilia, increased neutrophils. Other causes of increased neutrophil count is trauma, burns, surgery, inflammations like polymyalgia rheumatica and rheumatoid arthritis. Myocardial infarction will also cause increased neutrophil counts. Pregnancy, malignancy, leukemias, yes, definitely leukemias with a specific lineage, cell lineage will cause increased neutrophils. Disseminated malignancies will cause, because that will infiltrate the bone marrow. Drugs like steroids will increase the neutrophil count. Causes of decreased count, mild 1 to 2 into 10 power 9. So mild decrease in neutrophil count and moderate decrease in neutrophil count, severe decrease in neutrophil count. So 2 to 7.5 is normal. So 1 to 2, viral infections like mumps, hepatitis, influenza. These will cause decrease in neutrophil counts, increase in lymphocyte counts. Drugs, example carbimazole or cytotoxic drugs. Idiopathic or immune, benign ethnic Afro-Caribbean patients have less neutrophils. If less than 1 into 10 power 9, discuss with a hematology and refer. Warn about the risk of neutropenic sepsis. If less than 0.5, refer urgently to hematology. So this less than 1000 neutrophils, refer routinely to hematology and discuss with hematology and refer. And if count is less than 500 neutrophil count, then refer urgently to hematology. Lymphocytes. So normal count is 1.5 to 4.9 into 10 power 9, which should make up to 20 to 45% of the total WBCs. Viral infections. Causes of raised lymphocyte counts are viral infections. That's we have already read. In viral infections, lymphocytes will be increased and relatively neutrophils will be decreased. EBV, early HIV, hepatitis and rubella will cause lymphocytosis. EBV, early HIV, hepatitis and rubella. Other infections, whooping cough, toxoplasmosis. These are the two bacterial infections. Whooping cough and toxoplasmosis will cause increase in lymphocyte counts. CLL and ALL, large number of abnormal atypical lymphocytes is characteristically seen with EBV infection. Drugs, example, cytotoxic drugs will decrease the lymphocytes. Cytotoxic drugs and steroids decrease the lymphocyte lineage. Systemic diseases like influenza, SLE, uremia, HIV infection decrease lymphocyte count. Influenza, SLE, uremia, HIV infection decrease the lymphocyte count. Unless other hematological abnormalities, never needs hematology referral for decreased leukocyte count. Monocytes 2.2 to 0.8 into 10 power 9, 2 to 10%. Chronic bacterial infections, example, N by A, I don't know what is N by A, tuberculosis or systemic bacterial subacute bacterial endocarditis. So chronic bacterial infections will cause increased monocyte counts. Tuberculosis and subacute bacterial infections, endocarditis and autoimmune disorders. So this is not applicable. That is, there is never a decreased monocyte count. We don't have to take into consideration. Only increased monocyte count in seen in chronic bacterial infections, tuberculosis and SB, and autoimmune disorders. So whenever you see a monocytosis more than 10%, you should consider investigation for tuberculosis, SBE, chronic infections, or autoimmune disorders. Eosinophil count 0.04 to 0.44. 0.04 to 0.44 and should be 1 to 5%. If mildly increased less than 1.5 in well patient, do not investigate further. If it's only mildly increased less than 1000 cells, do not investigate further. It's normally 40 cells to 440 cells. Causes of increased eosinophils is atopic disease like asthma, parasitic infections, hematological diseases, malignancies. Hematological malignancies will cause eosinophilia. Allergic or atopic skin conditions, solid tumors, GI disease. Allergic or atopic skin conditions, solid tumors, GI disease, inflammatory bowel disease, celiac disease, lung diseases, 1% cases, connective tissue disorders in 0.5% of the cases. So, high eosinophil count will be seen in atopic disease, example asthma, parasitic infections, 8% of the cases, hematological malignancies, 2.5%. The most common causes, atopic disease or asthma. Other causes, hematological allergic atopic conditions, solid tumors, GI disease, lung disease, connective tissue disorders. GI disease, connective. So, basophil counts. Normally 10 to 100, less than 1% of the WBC count. High basophil counts are seen in CML or myeloproliferative disease, hypothyroidism, drugs like estrogen. CML, myeloproliferative disease, hypothyroidism or drugs like estrogens. Page number 638, anemia, diagnosis and initial investigation. Anemia. Anemia is lack of sufficient red blood cells and thus hemoglobin. Males, the hemoglobin less than 13 is considered anemia. In females, hemoglobin less than 12 or less than 10, 11 in the first trimester and less than 10.5 in the second and third trimesters of pregnancy is considered anemia. If the results, it results if there is decreased red cell production, defective precursor proliferation or maturation, increased rate of red cell destruction, bleeding or hemolysis, decreased tissue requirement of oxygen. Usually hypothyroidism. So that's why in hypothyroidism there will be anemia. Presentation. Patients who become anemic slowly may remain asymptomatic for a long time. As anemia progresses, pallor, exertional dyspnea, tachycardia, palpitation, angina, specifically if past history of coronary artery disease, night cramps, cardiac bruits appear. Ultimately, with severe anemia, high output cardiac failure may appear. Pallor. may be indicate anemia but is very non-specific sign which may also be racial, familial or cosmetic. Other causes of pallor are shock, Stokes-Adams attack, vasovagal faint, myxedema, hypopituitarism and albinism. Stokes-Adams attack, vasovagal faint, myxedema, hypopituitarism, albinism. Initial investigations of anemia, table 18.2. Management. Treat the cause if no cause is found, refer for further investigations. So this is the causes of investigation for causes of anemia, into the causes of anemia. Mean corpuscular volume you have to do, low, less than 80 picoliters. Causes could be iron deficiency, hemoglobinopathies like thalassemias, anemia of chronic disorders. Potential further investigations. You do a blood film. You do a reticulocyte count. You do ferritin, CRP, ESR and plasma viscosity. Hemoglobin electrophoresis if indicated. So initially when there is iron deficiency anemia, you do a blood film. You do a reticulocyte count. Sorry, not iron deficiency. When you have a anemia with low MCV, blood film, reticulocyte count, ferritin, CRP, ESR, plasma viscosity, HB, electrophoresis if indicated after all these. Normal. Acute blood loss, hemolysis, anemia of chronic disorder, uremia, hemoglobinopathy, marrow failure. So normocytic anemia, that is MCV is normal, normocytic anemia could be due to acute blood loss, hemolysis, anemia of chronic disorder, uremia, hemoglobinopathy or marrow failure. You do a blood film, reticulocyte count. So reticulocyte count will tell you, high reticulocyte count will tell you that there is sufficient hematopoiesis is going on, and hemoglobin electrophoresis for hemoglobinopathies, ferritin levels for iron deficiency, serum or acute phase reactant because anemia of chronic disease, and serum B12 levels, serum and red cell folate levels, renal function and serum bilirubin. B12, red cell folate levels, renal function and serum bilirubin. When the MCV is high, folate or B12 deficiency, alcohol, liver disease, thyroid disease, myelodysplasia or marrow infiltration. So you do a blood film, serum vitamin B12, serum red cell folate, liver function, thyroid function test. Vitamin B12 deficiency. Vitamin B12 is found in liver, kidney, fish, chicken, meats and dairy products. Absorption takes place by active or passive mechanisms, the latter being dependent on the intrinsic factor and passive mechanism dependent on the intrinsic factor, a protein produced by GI parietal cells. Deficiency presents with macrocytosis or with symptoms and signs like glossitis, mouth ulcers, peripheral neuropathy, ataxia, optic atrophy, memory loss, subacute combined degeneration of the cord, and rarely psychosis will be there as a part of B12 deficiency. B12 levels correlate poorly with the deficiency, especially in pregnancy. If the strong clinical suspicion is there but normal B12 levels are there, discuss with hematology. Causes of deficiency. Inadequate dietary intake, example vegans, malabsorption, GI diseases or surgery, gastric, example H. pylori infection, pernicious anemia or gastrectomy. Gastric causes, H. pylori infection, pernicious anemia, gastrectomy. Pancreatic causes, example chronic pancreatitis, ileal causes, celiac disease or ileal resection. Drugs like metformin, drugs causing echlorhydria, examples H2 agonists, antagonists, PPIs, combined oral contraceptive pills may decrease the B12 levels due to decreased carrier protein and not deficiency. CO pills may also decrease the B12 levels. due to reduction in karyoprotein, but not due to deficiency. Pernicious anemia, autoimmune condition associated with gastric atrophy and intrinsic factor, 50% gastric parietal cell, 85% antibodies. So, autoimmune condition with anti-intrinsic factor antibodies or gastric parietal cell antibodies. Mostly gastric parietal cell antibodies, 85% cases, intrinsic factor antibodies in 50% of the cases only. Risk factors for pernicious anemia, family history, other autoimmune diseases like vitiligo or hypothyroidism, premature graying of the hair, blood groups A, HLA13, HLA3. So this one thing, blood group A type is also uh, associated with pernicious anemia. Associated with increased risk of stomach, colorectal cancer, particularly if less than 2 years after diagnosis. High risk of stomach cancer, colorectal cancer, less than 2 years after diagnosis. Management. Treat with vitamin B12 hydroxycobalamin IM 1 milligram 3 times per week for 2 weeks, then every 2 to 3 months. So how do you treat B12 deficiency? Give hydroxycobalamin IM 1 milligram into 3 per week. So in a week you have to give 3 times first, and then 2 weeks, and then every 2 to 3 months. So initially course will be 6 injections in the first 2 weeks, and then every 2 to 3 months you will give 1 injection. Confirm response by repeating FBC after 2 and 8 weeks. So you have to repeat an FBC after second week and 8 weeks. So after first 6 injections you will repeat an FBC, and then after 8 weeks again 2 months you will repeat an FBC. Consider oral B12 supplements if borderline results and non-specific symptoms. Consider referral to exclude other GI causes. So this was the management of B12 deficiency anemia. Folate deficiency anemia. Folate is found in highest concentrations in the liver and yeast, and also in spinach and other green vegetables and nuts. Deficiency presents with macrocytosis. Symptoms and signs of anemia. There will be symptoms and signs of anemia, pes, polyneuropathy or dementia, mouth ulcers, same like vitamin B12. Then check vitamin B12 deficiencies may coexist. So causes of deficiency. So when there is folate deficiency, you have to check for vitamin B12 deficiency also, because they coexist. Causes of deficiency: inadequate dietary intake, common; old age, poor social conditions, malignancy, anorexia, excess alcohol, particularly spirits. Malabsorption, like in celiac disease, Crohn's disease, partial gastrectomy, tropical sprue, lymphoma or diabetic enteropathy. Excess use, pregnancy, lactation, prematurity, increased cell turnover, example malignancy or hemolysis. Excess use, pregnancy, lactation, prematurity, increased cell turnover, example malignancy and hemolysis. Drugs, anticonvulsants, trimethoprim. So this will cause anticonvulsants, and trimethoprim will cause folate deficiency. Trimethoprim will cause folate deficiency. Management: tweak the cause. Supplement with folic acid 5 milligrams OD for 4 months. If there is deficiency, established deficiency, 5 milligrams OD for 4 months. If malabsorption, may need increased dose, that is 50 milligrams OD, 1-5. And treat the B12 deficiency if it is coexisting. For prophylaxis in chronic hemolytic states or for renal dialysis, up to 5 milligrams OD of long-term use is used. Long-term is used. Take specialist advice. For prophylaxis in chronic hemolytic states or for renal dialysis, 5 milligram OD for long term. Folate supplementation in pregnancy. Advise women to take supplements from planning pregnancy to 12 weeks of gestation to prevent neural tube defects. Dose to prevent first occurrence is 400 micrograms OD. If family history of neural tube defects are present, or if mother has a BMI more than 30, diabetes, sickle cell anemia or celiac disease, or is taking anticonvulsants, or to prevent recurrence in case there was a previous neural tube defect, then 5 milligrams OD from the time of planning pregnancy to 3 months after conception, that is 12 weeks of gestation. Page number 640, iron deficiency anemia. Most common form of anemia in the UK. Prevalence is 2 to 5% among adult men and postmenopausal women. Red blood cells are microcytic, decrease MCV and hypochromic. Low serum ferritin or low transferrin saturations confirm iron deficiency. Exclude hemoglobinopathy in those with family history or from at-risk ethnic groups. Exclude a hemoglobinopathy who have a family history of iron deficiency anemia. Page number 644, hemoglobinopathies. Causes of iron deficiency anemia. More than one cause can be present. GI blood loss, aspirin or NSAID use, 10 to 15% of the cases. Colonic carcinoma, 5 to 10%. Gastric carcinoma, 5%. Benign gastric ulceration, 5%. Angiodysplasia, 5%. Esophagitis, esophageal carcinoma, rarely. Malabsorption syndromes like celiac disease may be the presenting feature of post-gastrectomy. Celiac disease may be the presenting feature post-gastrectomy, H. pylori colonization and gut resection. Non-GI blood loss, menstruation, non-GI blood loss like menstruation, blood donation, hematuria, epistaxis. Other causes are pregnancy, lactation, premature infants, deficient diet. Pregnancy, lactation, premature infants and deficient diet. Investigations and management in iron deficiency anemia. Treat the underlying cause when possible. Give iron supplements. Ferrous sulfate 200 mg BDPO may turn stools black and cause constipation. If not tolerated, try lower dose of alternative preparation. Example, ferrous fumarate. So ferrous sulfate first, or else if not tolerated, then ferrous fumarate. Fruit juice rich in vitamin C may be taken along with iron and may increase iron absorption. Hemoglobin should be high, raised by, yes, this is important. Hemoglobin should be raised by 1 gram per day, deciliter per week by oral supplementation. Confirm response 2 to 3 weeks after starting treatment. Continue treatment for more than 3 months after correction of deficiency to replenish the iron stores. Asymptomatic colonic gastric cancer may present with iron deficiency anemia. Refer via suspected cancer pathway if iron deficiency plus more than 60 years or a rectal bleeding and more than 50 years. So, if there is iron deficiency in a patient more than 60 years or there is rectal bleeding in a patient more than 50 years with iron deficiency, you can send for a 2-week cancer referral. Use quantitative fecal immunochemical tests. Quantitative fecal immunochemical test for those who do not meet these criteria. So if it is not one of these two, you first do an immunohistochemical test to confirm whether it is hemoglobin that is coming out, red blood cells that is and hemoglobin that is in the stools, and refer via a suspected colorectal cancer pathway where tests show occult blood in the feces. After the immunohistochemical test. Failure to respond to iron supplements. Consider H. pylori infection, test and treat. Celiac disease, oral iron is not absorbed. Continuing bleeding, non-compliance with iron, diagnosis is incorrect or anemia is mixed. Follow-up. Once blood count is normal, monitor hemoglobin, MCH, MCV every 3 months for 1 year and then annually. So whenever blood follow-up of anemia, blood count is normal, you need to monitor hemoglobin, mean corpuscular volume and MCV every 3 months and for 1 year and then annually. Give further iron supplements if hemoglobin, MCH, MCV falls below the normal levels. Investigate further if unable to maintain hemoglobin. So after you have given a full course and the hemoglobin has been raised, and then when you are doing your follow-up, that is every 3 months for 1 year, and then annually, and then again the hemoglobin levels or MCV levels or MCH levels falls below normal, you need to investigate further why they are not able to maintain the hemoglobin. Iron deficiency without anemia. Low serum ferritin, hypoferritinemia, is 3 times as common as iron deficiency anemia, with this very low prevalence of GI malignancy in this group of patients. So investigate as in figure 18.1. Give iron supplements to replenish the iron stores. Iron deficiency anemia, this is a flow chart for management. Investigation and management of iron deficiency anemia. Let's see that. Evidence of iron deficiency anemia. First, there should be low ferritin, microcytosis, hypochromia on a peripheral smear. Is there an overt GI cause of blood loss? Or example, non-GI cause of blood loss. Example, menorrhagia. Dip the urine for blood. So you have to check for menorrhagia, ask for menorrhagia and dip the urine from blood if there is hematuria. Yes, then treat the cause. No, then check celiac serology. If celiac serology is negative, yes, then why the patient has anemia, we have to rule out. If celiac serology is positive, yes, refer to gastroenterology for confirmation of diagnosis by small bowel biopsy. So in case your celiac serology is negative, yes, anemia, and there is anemia, yes, menstruating woman, yes, upper GI symptoms. So if the celiac serology is negative, anemia is present, menstruating woman, then any upper GI symptoms are present or not. If yes, refer to esophagoduodenoscopy or upper GI endoscopy. Okay. If that is normal or not, you have to see. If upper GI endoscopy is abnormal, manage detected condition. Whatever condition is causing this blood loss from the GI tract, you have to manage. So in this case, again, if anemia is present and there is evidence of iron deficiency anemia, that is low ferritin, microcytosis, hypochromia, and uh, there is no overt blood loss, there is no dipstick blood loss, there are no hematuria, no celiac serology is negative, then anemia is not present, age more than 50 years, yes, if it's a menstruating woman, then again follow the same flow chart. If no, if the woman is not menstruating, then refer for colonoscopy or CT colonoscopy, colonography, and esophageal gastroduodenoscopy. So you have to, if patient is not menstruating, you have to find out other non-menstrual causes of GI blood loss. So you do a causes of blood loss, that is colonoscopy, CT colonography, and esophageal duodenoscopy. If all of these are normal, then just give iron replacement, treat menorrhagia with Mirena, refer for further investigation for transfusion dependent or ongoing anemia when menorrhagia is controlled. If normal, no, manage the detected condition, my detected GI condition. If age is more than 50 years, no, give iron replacement. If age is less than 50 years and still you are not able to detect what is the cause of anemia, then better you give iron replacement first. And even after iron replacement, there is iron deficiency. Yes, then if it's a menstruating woman, you do the upper GI endoscopy. Again, iron deficiency is present. No, after iron replacement, no further investigation is needed. So it depends on the age. After a celiac screen, depends on anemia is present or not and age of the patient. If age is more than 50, then you have to further evaluate by an either upper GI endoscopy if upper GI symptoms are present, or no symptoms, upper GI symptoms are present, then you have to do both colonoscopy, CT colonoscopy and upper GI endoscopy, all three of them. If age is less than 50 years and there is anemia and celiac serology is negative, urine dipstick and menorrhagia is not present, then just give iron replacement. Give iron replacement and check for iron deficiency after iron replacement. If still present, then you further evaluate the endoscopies, or else if iron deficiency is not present or curtailed, then no further investigation is needed. So it's a very extensive flowchart. Referral for colonoscopy, CT colonography should be urgent. That is to be seen in less than 2 weeks if age more than 60, age more than 50 and rectal bleeding or a fecal blood test is positive. That's all for today, doctors. Tomorrow we'll continue from page number 642, other anemias. Thank you. Have a good day.